Thank you very much and good afternoon, everybody. I thank the organizers for inviting me to be here among this illustrious group of speakers. I'd like to talk to you about, I was asked to talk to you about native liver Doppler ultrasound. I have nothing to disclose, so what I'd like to do in the next 25 minutes or so is give a very brief review of the normal vascular anatomy, and then we'll look at some of more common problems that we encounter, such as portal vein thrombosis, cavernous transformation of the portal vein. We'll look at some findings in Budd-Chiari syndrome and end up with transjugular portosystemic shunts. So as you all know, the portal vein is the vessel that supplies most of the blood to the liver, about 70 to 75%. It is formed by the confluence of the superior mesenteric vein and the splenic vein. The portal vein divides, the main portal vein divides into the right and left portal vein within the liver. And on Doppler, it has a characteristic hepatopedal monophasic blood flow. There is some variation with the respiratory phases, and there's also something called helical flow, which is a normal variant. So here you have the normal main portal vein as it goes into the liver. It is hepatopedal with continuous forward flow, low velocity, it's non-pulsatile, and there are changes with respiratory variation. Obviously, the left portal vein is also antegrade in flow, displayed above the baseline, and then the right portal vein dives deep into the right lobe, and therefore you have the flow displayed below baseline. This is what you sometimes can see. This looks like a yin-yang type appearance in the portal vein. That's the helical flow. That's a normal variant. The normal diameter, as we just heard already from Dr. Dogra, is 13 to 16 millimeters. You have to remember that diameter varies. If the patient is postprandial or takes a deep breath in, the diameter increases. And if the patient has been fasting or is post-exercise, the diameter decreases. The normal velocity is anywhere between 20 and 30 centimeters per second. Sometimes you see a little bit of pulsatile flow in the portal vein. That can be seen in normal, very muscular, athletic young subjects. However, if it becomes more prominent or if you see it, you should think about other conditions that can cause it, such as congestive heart failure, hepatic to portal vein fistula, or portocaval shunts. I think I had an image in there of the normal portal vein that didn't transmit. Here, however, you see a patient where here's the portal vein. It's big. It has very marked pulsatility to its flow. And this was a patient with congestive heart failure. You can also see this on the venous side. You see marked dilatation of the hepatic veins. Here's another patient with very pulsatile portal venous flow, and you can see in this patient patient has tricuspid regurgitation. Sometimes you see pulsatile flow in both the portal vein, as here, and also the hepatic veins, and this is, again, patients who have congestive heart failure who exhibit this pattern. The hepatic artery is the next, the arterial supply to the liver, which accounts for about 25% of blood flow to the liver. It arises from the celiac axis in most patients, and it runs in the hepatoduodenal ligament anterior medial to the portal vein. Here you can see the hepatic artery coming off the celiac and diving into the liver. An apparent hepatic artery does exist. Most of the time it's the right hepatic artery that is replaced and arises from the superior mesenteric artery. And the hepatic artery has a low impedance flow pattern on Doppler ultrasound with a sharp systolic upstroke and good flow throughout diastole with continuous forward flow. And here you can see again, the normal hepatic artery, sharp upstroke, and continuous flow throughout diastole. And similar to the portal vein, the right hepatic artery dives deep into the right lobe to supply the right posterior right lobe, and therefore the flow is displayed below baseline. The hepatic veins demonstrate a triphasic hepatofugal flow pattern. There is forward flow with right atrial filling, and there's a rapid and a slow phase of this right atrial filling, and then there's transient reversal of flow when the right atrium contracts. In patients who have right heart failure or tricuspid regurgitation, you can see a very pulsatile hepatic venous pattern like I already showed you, and this has been termed the W waveform. Conversely, if the patient has intrinsic liver disease or cirrhosis, the flow within the hepatic veins will be dampened due to the increased peripheral resistance. So here's your normal. This is atrial filling, the rapid and the slow phase, and then when the atrium contracts, you see transient reversal of flow, and you see the same thing right here, and here's the transient reversal. Now here you see the W waveform. It's very, very pulsatile flow within this patient with congestive heart failure, also seen on the gray scale as dilatation of the hepatic veins. And look at this patient here with liver cirrhosis. There's surface nodularity, there's a little bit of ascites. The hepatic veins here look like portal veins. They're completely dampened with monophasic flow. So what are some of the etiologies of portal vein thrombosis? Well, there's a whole long list, but the most common ones are, you can see them in liver cirrhosis, pyelophlebitis and omphalitis, especially in children, patients who have acute pancreatitis, and then patients who have hepatocellular or cholangiocarcinoma, hypocoagulable states, penetrating trauma can cause portal vein thrombosis, and then some rarer endoscopic sclerotherapy, and then there's also an idiopathic version. What do we see on ultrasound? Well, portal vein thrombosis looks like thrombosis anywhere in the vein. You see dilated portal vein with internal echoes. You see absence of flow in the portal vein. You have to be very careful to optimize your color Doppler sensitivity because you could get false portal vein thrombosis due to very, very slow flow. And if you really cannot tell, you have optimized and done everything you can, you might have to go to another imaging modality. And in my next version, I'll put contrast-enhanced ultrasound way up here over CTA and MRA. The thrombus in the portal vein can also be echogenic as it ages. And sometimes you just can't really see the thrombus. You just don't see the portal vein or its branches, so you assume it's thrombosed. If there's partial thrombosis, you will see a little bit of flow around the clot. And a secondary sign of portal vein thrombosis is enlargement of the hepatic artery, because the hepatic artery now has to supply more blood to the liver to compensate for the missing 75% that the portal vein used to supply. So when you see enlargement of the hepatic artery in a diffuse fashion, think immediately about, could this patient have portal vein thrombosis? But you can also see it in patients with very severe cirrhosis because, again, the portal venous inflow is impeded and decreased. And, of course, large hepatocellular carcinomas, because they're fed by the hepatic artery, will lead to enlargement. If you see focal enlargement of the hepatic artery, think about hepatic artery aneurysms or pseudoaneurysms. So here's a patient who has portal vein thrombosis. Here's the region of the portal vein. We don't really see much of a normal vessel. You see the cirrhotic liver with ascites. And here when you put on color Doppler, you see the hepatic artery is quite prominent and the portal vein is completely thrombosed. Here's another case where you see portal vein thrombosis, and look the beautiful appearance of this large corkscrew-like hepatic artery with increase in flow now up to 242 centimeters per second. This compensatory work that the hepatic artery does to accommodate for the decrease of venous flow through the portal vein. Malignant portal vein thrombosis, as I just learned, I guess we call it now tumor thrombus in vein, so we have to change this. It occurs when you have non-occlusive thrombus with some internal vascularity, and you might think, is this residual vein that hasn't just been caught by the thrombus? But very important, you put your spectral waveform in and you can see the characteristic arterial spectrum to this flow. So this is tumor thrombus. Here's another nice example. You can see an enlarged portal vein here filled with hypoechoic thrombus. And then here's this vascular structure in the center. Again, putting on your spectral waveform, you see this is arterial flow within this thrombus in vein. This is a patient who had undergone a wound to his abdomen, and his portal vein and hepatic artery area looked like this. Here's the hepatic artery, and there was this pseudoaneurysm post-traumatically, accounting for the focal enlargement of the portal vein. Cavernous transformation of the portal vein occurs in about half of the patient with portal vein thrombosis. It is due to development of periportal and perigallbladder collaterals within the hepatoduodenal ligament. It can occur as early as 6 to 20 days after portal vein thrombosis, and it's commonly associated with the development of esophageal varices as well. What do you see on color Doppler ultrasound? You see a tangle or a cluster of irregular vessels in the region of the porta hepatis and in the gallbladder wall. And you can also see intrahepatic collaterals or recanalization of the paraumbilical portal vein, as Vikram just showed you. So here's the grayscale appearance of cavernous transformation within the porta hepatis. You see these tangles of serpiginous anechoic structures. You put on color Doppler, you see vascular channels, but you do not see a normal portal vein. Moving on to Budd-Chiari syndrome, again, multiple etiologies. Some of them are very similar to those of the portal vein thrombosis, so cirrhosis, thrombosis of the portal vein, and then important congenital webs or bands within the veins, neoplasms, and then you can read the rest of the list. So the outflow obstruction of the veins occurs at the level of the hepatic venules, the large hepatic veins, or the inferior vena cava in Budd-Chiari syndrome. These patients have a very nonspecific clinical presentation. They come in with a large liver, they have pain in their abdomen, they might present with ascites and also lower extremity edema. So what do we see on ultrasound in Budd-Chiari syndrome, or findings that should clue you into this? Within the portal vein, we can see signs of post-hepatic portal hypertension. The flow might be hepatopedal or hepatofugal. In 10%, the portal vein can be thrombosed, and you will see the development of portosystemic collaterals. Within the hepatic veins and the inferior vena cava, you can see narrowing, you can see web formation or frank occlusion. Sometimes you see focal areas of calcifications. So here's a patient with Budd-Chiari syndrome. Look at this middle hepatic vein here. There are all these middle hepatic vein webs. This patient also had a very large hypertrophied caudate lobe, which you can see in Budd-Chiari syndrome. Here's another patient where you look at the middle hepatic vein, and it's visible on grayscale, but there's no flow within it. And in this patient, we also see echogenic thrombus within the inferior vena cava. Here's a patient who had occlusion of all three hepatic veins. This is the area where the hepatic veins should be joining the inferior vena cava, and we see nothing on grayscale, and we see nothing on color Doppler ultrasound. Some of the therapeutic measures in Budd-Chiari syndrome include a beginning of thrombolytic therapy, shunts for decompression of the hepatic vasculature. In the past, we had surgical mesoatrial and mesocaval shunts, and then in the last few decades, these patients have been successfully treated with tip shunts, and ultimately, these patients might need liver transplantation. So that leads me into talk in my last part of the presentation about portosystemic shunts. They are performed to decompress the portal system in patients with symptomatic portal hypertension and to relieve the gastroesophageal bleeding that can occur from varices and the development of refractory ascites. Previously, we had surgical shunts, the mesoatrial shunt, the mesocaval shunt, the portocaval shunt, and the distal splenorenal or Warren shunt. These have been replaced in the vast majority of patients by percutaneous TIPS shunt in the last 2 decades. So transjugular intrahepatic portosystemic shunts are now the preferred alternative to surgical shunts for complications of portal hypertension. The advantages are that TIPS shunts avoid major surgery, and they also do not alter the extrahepatic vascular anatomy. With TIPS shunts, you gain transjugular access of the infrahepatic inferior vena cava, and then select the most optimal hepatic vein based on the angle and diameter to place the shunt. Usually it is the right hepatic vein. So then you perform a transjugular puncture between the hepatic vein and the intrahepatic portal vein under either ultrasound or fluoroscopy. You place a metallic expandable stent between the hepatic vein and the portal vein to divert blood flow from the high pressure portal system into the lower pressure systemic circulation. And you monitor portal pressure gradients and filling of varices on portal venography. What are some of the indications for TIPS shunts? Variceal bleeding, refractory ascites, the Budd-Chiari syndrome, hepatorenal syndrome, liver failure, to give the patient a chance to become a potential candidate for liver transplant by being put on the wait list because of an intermediary help from the TIPS shunt that allows the patient not to continue to go into liver failure. So it's kind of just a middleman while the patient still has hope to be placed on the transplant list for definitive treatment. Contraindications, there are a lot of not absolute contraindications that I'm not going to mention, but I want to just point out the 2 absolute contraindications to TIPS shunt placement are inadequate liver reserve, i.e. if the patient has severe hepatic encephalopathy, because that may worsen the encephalopathy by now dumping all that extra blood into the systemic circulation, and severe right-sided heart failure, because that may exacerbate the patient's condition by leading to volume overload. So let's look at normal TIPS shunt. The early experience, it started in the early 90s. So the early experience is that 1 decade between 1993 and 2003. The shunts that were used were bare metallic shunts. They were a great success, but they only had a patency rate of about 40 to 60% at 1 year. So then someone developed expanded polytetrafluoroethylene PTFE covered devices, the Viator stents that are still being used today, and they have been in use since 2003. And the big advantage of the Viator PTFE covered shunts were that they have a patency rate of 80 to 90% at 1 year. On ultrasound, the walls of the stent are brightly echogenic. They should be smooth and parallel. When you turn on your color, it should fill the entire lumen of the shunt. And be very careful, though. We have learned that in the very early phase post-placement of the PTFE covered shunts, you can get an artifact that mimics portal shunt thrombosis, because there is some air embedded in the stent, and as the stent expands, this air gets released and then causes a very bright shadowing artifact along the stent, which presents Doppler interrogation deep to it. So here's your normal shunt, nice parallel grayscale echogenic regions. Put on color, you see nice color filling through the proximal, mid, and distal shunt. And here's a patient. This was actually a resident overnight, read this case. They had placed the shunt the afternoon before, wanted to see if the shunt was patent, and all the sonographers could find was this one bright echo. There was nothing distal to it. They put on color and they saw no flow, so they called it shunt occlusion. Well, fortunately, the interventional radiologist knew better and said, let's just repeat the patient in the next 24 to 48 hours. And of course, the shunt was patent. So the recommendation is do not interrogate these PTFE-covered shunts or stents within the first 72 hours of placement if you're not aware of this artifact. If you are aware of it, you can say, well, we can do it, but it's going to be useless because I can't really tell you much about it. So what are the what's the normal Doppler appearance of normal tips? There's been a lot of variability in the literature, multiple studies out of Mallinckrodt, out of UCSF several years ago, but people generally agree that the lower and upper limits of flow through the shunt are anywhere between 90 to 190 or 100 to 200 centimeters per second. After shunt placement, the flow in the main portal vein increases. It should be more than 40 centimeters per second, and the flow in the hepatic artery will also increase greater than 130 centimeters per second. Very importantly is that the flow in the main, the right, and particularly the left portal vein, if the shunt is properly functioning, should now go out of the liver, so it should be hepatofugal towards the lower conduit, lower pressure conduit of the shunt. So reversal of flow in the left portal vein is a normal finding in a normal TIPS shunt. So here you can see normal flow in the tips, and if you look at the left portal vein here, it is coming down towards the TIPS shunt within a hepatofugal flow fashion. That is normal. The velocities across in this patient were between proximal, mid, and distal, anywhere from 143 to 173, so that is normal. This is a nice normal shunt. What are some of the complications we as ultrasonographers are asked to evaluate after TIPS shunt placement? Well, there are complications related to the vascular puncture, and then there are complications related to the TIPS itself. So what we can see are subcapsular hematomas, hemophilia, blood in the gallbladder, sometimes hepatic artery injury, pseudoaneurysms or AV fistula, but these are more common if the puncture is blind and not with guidance, and then frank hemoperitoneum can also occur. Here is one patient who had developed a subcapsular liver hematoma, and then here in the same patient you see this is the gallbladder, it's filled with blood. This patient developed a pseudoaneurysm of the hepatic artery after a TIPS shunt placement, and this was successfully coiled. You see it nicely here on the angiography, also had an associated AV fistula, and after coiling, the patient's angiogram looked good, and you can also see the flow within that pseudoaneurysm is gone, and there's just now this echogenic artifact that you can oftentimes see after coil placement. The technical success is fairly high in experienced hands. However, there is associated morbidity and mortality, and all those, of course, depend on the patient's pre-test condition. If the patient is very sick, the morbidity and mortality are much higher. However, it has been shown to be over 90% effective in controlling variceal bleeding. When should you worry about malfunctioning of the tips? When you see reappearance of varices, when the ascites recurs, and when you see development of pleural effusions. And these are due to either tip stenosis or thrombosis or shunt retraction. Be careful sometimes if the shunt is really, really deep in the abdomen. If the patient is very big, you could false positively identify an occlusion or thrombosis. So complications due to pseudointimal hyperplasia or thrombosis result in TIPS stenosis or TIPS occlusion. And usually if you have TIPS stenosis, you will see incomplete filling of the stent and decrease in the velocities. People have usually agreed upon if it's less than 60 centimeters per second, if you see high velocities at the site of stenosis, and if there is a velocity gradient across the shunt of greater than 60 centimeters per second, that's indicative of stenosis. Occlusion, obviously you see no flow in the shunt at all, and you will in the left portal vein see reversal back into the liver, so we see hepatopedal flow in the portal branches. The exact cause and pathophysiology of the stenosis are unknown. There are several etiologies and pathologies that have been speculated. People have said there is some faulty development of that PTFE. It becomes then porous and it allows bile leaks and ingrowth of tissue. There could be propagation of neointimal or pseudointimal hyperplasia, usually from the ends, particularly from the hepatic venous end, more than the portal venous end, into the shunt. And then sometimes you just have diffuse laminar thrombosis without tissue ingrowth. The reported criteria are all over the map. I was once at a meeting and someone said, why don't we just even worry about giving velocities and criteria, just say it's patent or it's not, but I don't think that's good enough. So what most people agree upon, tip stenosis should be suspected when the velocity in the main portal vein all of a sudden drops. I told you it should be more than 40 centimeters per second. When it's less than 30, if the velocity in the tips itself is less than 50 or 60 centimeters per second, if there are focal shunt velocities greater than 200 centimeters per second, and if there is a temporal or longitudinal change in tips velocity across the shunt, either an increase or decrease of 50 to 60 centimeters per second. And then, as I already mentioned, if you see hepatopedal flow in the left portal vein and hepatofugal flow in the main portal vein, that means the shunt is not functioning. Couple examples. Here's a patient who had all of a sudden reappearance of ascites. In the left portal vein, you now see hepatopedal flow. It goes back into the portal vein. The gradient across the tips between proximal and mid was more than 100 centimeters per second. Proximally it was 59, in the mid it was 168, and this patient had a stenosis. Here's another patient who had color aliasing at the hepatic venous end, and that's where the intimal ingrowth occurs most commonly. There's marked decreased velocity in the proximal tips. It only measures 44 centimeters per second, so less than the 60. The peak systolic velocity at the stenosis is 218, and there's hepatopedal flow in the left portal vein. And you can see right here, there's the stenosis. It was stent graft placement and angioplasty, and the patient did fine. The causes of thrombosis are also unknown. People have speculated there's a hyperdynamic phenomenon that causes competing shunts with stasis of the flow, which leads eventually to occlusion. Also, there's neglected or not recognized significant stenosis that goes on to blood stasis and thrombosis. Some people therefore recommend adequate Doppler surveillance so one can recognize the stenosis before they become critical to blood flow and cause thrombosis. Just a couple examples of occlusion. In this patient, the main portal venous flow was 18 centimeters per second, so markedly decreased. The flow in the proximal tip was 29, so markedly decreased. And then in the mid and distal tips, there was no flow. You can also see this nicely here on the grayscale and the color Doppler and even power Doppler image. Again, you want to, of course, make sure you optimize all your colored Doppler settings. Here's another patient with occlusion. You see decreased flow in the main portal vein, 8 centimeters per second, hepatopedal flow in the left portal vein, and then complete occlusion. Actually, there was also reversed flow in the main portal vein with low velocities, and the entire tips was occluded. Couple pitfalls real quick. Deep location in the abdomen can make evaluation very difficult. And then there was a really nice paper that Dr. Cleaver published many years ago where he showed that there was actually a difference of flow velocities between in and expiration, which we know from the normal portal vein. that there was 22 centimeter less flow with deep inspiration compared to expiration. So it would be ideal if you follow these patients sequentially. We tell our patients to do like comfortable mid-respiration, so no deep in, no deep out or expiration. But it would be helpful to put that on your screen so that when you see the patient again, you know in what phase of the respiratory cycle this was taken. So here's a patient where we see good flow in the proximal and mid tips, and then it dives so deeply in the distal tips that we couldn't really see it. This was actually patent as proven by angiography afterwards. So in conclusion, Doppler ultrasound of the native liver is very important. It allows assessment of physiology and pathophysiology of the vessels and associated conditions. We have discussed the normal appearance of the vasculature. We have looked at portal vein thrombosis, cavernous transformation, the Budd-Chiari syndrome, and the TIPS shunt.